Thanks, Laura. Good morning, everyone. I'm Breed O'Brien, Deputy Director of Digital Health at NHSX, and I'm delighted to be chairing this session where you're going to hear short presentations from local teams from 4 of the 7 regions in England about their programmes of work as part of the Innovation Collaborative. And then we'll have a really important presentation on the subject of digital inclusion. But first, we'd like to play a short animation to summarise what this has all been about.
It's been a really busy time for frontline teams across England, implementing new digital technologies and innovative approaches to support people at home as part of the NHSX National Innovation Collaborative. More than 78,000 people across England have now benefited from the new ways we are delivering health and care services using digital technology. As well as working closely with local teams on the ground, the NHSX National Innovation Collaborative has formed a partnership with the Academic Health Science Network to rapidly share learning and best practice. Let's take a look at what's been happening. Supporting care homes has been a major focus, with examples of technology-enabled care happening in 1,200 care homes across England, reaching over 29,000 residents. COVID-19 has created major challenges for care home staff, residents and loved ones, but thanks to new digital tools, staff are now able to more closely monitor residents' health and report signs of deterioration quickly. This means NHS teams can work with care home staff to intervene early and ensure the right level of clinical care and support is provided to keep residents well in their home. For example, Priya's carers would usually have to call out a GP or an ambulance if they had any serious concerns about her health. But this isn't really the best option for her or busy health professionals. With the introduction of new, easy-to-use digital tools, Priya's carers, GP and specialist doctors can now keep track of her vital signs on a daily basis so they can act quickly. This way, care home residents can be safely monitored and professionals can work together to put the right level of clinical care in place to meet their needs. In response to COVID-19, health and care teams had to quickly find new and different ways to care and treat patients outside of hospital. By setting up technology-enabled virtual wards, health and care staff can now monitor patients remotely. This has saved 179 bed days over a 1-month period in one hospital alone, and similar benefits are being seen around the country. Over 18,000 people living with long-term conditions, such as heart failure or a respiratory illness, have been provided with technology, training and support to be able to self-care at home, while also being in close contact with their health professional who can monitor their vital signs remotely. This gives people more confidence to manage their own condition, while also feeling well supported by their health professional, driving a real partnership in care. There are many other examples of where technology has enabled enhanced care and treatment to be provided safely at home that may have previously needed a visit to hospital. This is just the start. Over the next year, we will continue to roll out digital health technologies to support more care at home, while sharing this learning through our Innovation Collaborative community to ensure that staff and patients benefit from these new innovations, wherever they are. Be part of the journey. Join the National Innovation Collaborative today.
So hopefully that's given you a flavour of things to come. So now we're going to hear from people who are part of the journey. We're delighted that all 7 regions have undertaken work in care homes as part of the programme. And the focus of our first 2 presentations are examples of great partnership working across health and social care. You'll hear these back to back. So firstly, we're off to the northwest to hear from Jay Hamilton in Manchester about their project to implement a COVID-19 tracker in care homes. And then we'll hear followed immediately by Mark Needham and Georgina Walton from the Southeast on their work in Kent and Medway on digital remote monitoring in care homes. So let's start with Jay.
My name's Jay Hamilton. I'm an Associate Director at Health Innovation Manchester in the northwest of England. And I'm here today to talk to you about our digital COVID-19 tracker that we placed into care homes during the COVID pandemic. Okay, so probably the best place to start is with the aim of the project. The aim of the project was really simple. We were trying to improve the way that carers, often non-clinically trained, could track symptoms of COVID-19 during this horrendous time of pressure and turmoil within the care home sector with this very vulnerable group of patients, residents as we describe them. We wanted to be able to track that in a daily, timely manner using technology that was simple to use, but created consistent, high quality communication tools to awaiting clinical teams should we need to escalate care or intervene with any clinical advice to the care home during a time where it was really important to keep the care homes as free from people coming in and out unless absolutely necessary. So that was the overall aim of this programme. We included a few other things in our thinking right from the start of this programme, in as much as we wanted this tool and technology to have longevity. So we wanted to contribute to the digital maturity of the system. So we wanted to help provide tools and technology, so equipment. So we worked with our local teams around building digital maturity around connectivity, the equipment that's used, etc. And we also wanted the tool itself to have a long-term impact. So we built into it an all-cause deterioration tool called Restore 2, and in particular focused on Restore 2 Mini, which the carers would value in terms of communicating soft signs of deterioration. Over time, we adopted an agile approach to our work. This was a tried and tested organisation that we'd worked with before, Safe Steps, but we needed to adapt the tool that we had used with them into a tool that would track COVID. So we did a hackathon. We brought in users, both clinical and carers. We created personas to make sure that this would work for the people it was most meant to affect. And we built a minimum viable product, which we were then able to test very quickly and then roll out at scale across all 10 of our localities, having tested it in one locality more deeply. That blueprint allowed us to engage with directors of commissioning. What would this cost in the future? To communicate with our DASs, which are our directors of adult and social care. So we were bridging gaps between health and social care, which was another aim and approach of the work that we were doing. We wanted this to have system thinking. We wanted it to point out to us where there were variations in our approach, etc. And we also wanted to look more deeply at the qualitative and quantitative impact of using digital technology like this in this setting. So the technology itself is a URL-based tool that will sit on any smartphone, iPad or tablet, and is very simple for the carer to use at the side of the bed and is expected to be used 2 to 3 times a week minimum, but we found that most of the end users used it on a daily basis. It improves the dashboard ability of the receiving clinicians to be able to respond to care needs within that care home. And let me just share some of the data and the measures that we got. As you can see, we managed to roll this out to 151 care homes. That was the last data point we took, although that's going up on a daily basis. We've done almost 369,000 assessments of residents in care, and that's to over 4,200 residents themselves across Greater Manchester. We've now set the tool up, and it's licensed for a further year, and we continue to develop adopt and spread methodology to try lift the blueprint that we created early in the programme into common use across the entire system itself. We have some of the key learnings I think that we have are around the technology is great, but unless you train the individuals, the carers at the bedside and the clinicians receiving this data, that's where the real secret sauce is created. Many thanks, and look forward to questions.
We'd like to tell you about digital remote monitoring in Kent and Medway. I'm Mark Needham from Health.
And I'm Georgina Walton from Social Care.
Our aims. In March 2020, we recognised there was an immediate need to move to digital pathways in primary care due to the pandemic. After the impact of Wave 1, we decided to build a digital bridge to care homes because the homes were cut off. And also during the winter, we used digital remote monitoring to support COVID patients and monitor their oxygen levels.
So what were the key elements of this project? Getting the foundations right was essential, and we had to ensure that we had a confident and competent digital literate workforce, care sector workforce, that could embrace a range of technologies, including digital remote monitoring. We approached this through a range of activities, which included training on Microsoft Teams to enable video consultations, NHS mail training to ensure the secure exchange of information, and introduced video care phones from Social Care, which was introduced during the pandemic to reduce social isolation and connect family with people with family and friends. We also distributed 550 iPads and delivered training on how to use these devices effectively, including a range of apps so that care workers could utilise the apps such as Help to Care, which was introduced in Kent and Medway for people that provided care and contains fundamental care elements to keep people well and out of hospital. We also connected 205 GP practices with 400 care homes.
Thank you, Gina. What was our approach to digital remote monitoring and technology? In December, we procured a digital communication system with 5,000 oximeters and 5,000 digital licenses. By providing apps for patients at home and care home staff, they could send their oxygen saturation levels, which could be monitored remotely by our clinical teams. Since then, we are now putting in place monitoring for 5,000 care home beds. We're extending the digital monitoring of a range of vital signs, including blood pressure, temperature, weight, and pulse. Digital remote monitoring has allowed us to be preventative and also to start doing monthly health checks. Digital remote monitoring also allows us to prevent deterioration and monitor more intensively patients outside of hospital. We would now like to talk to you a little bit about the outcomes and impacts of our work.
So what has been our key learning? It's really important for the health and social care partnership to work collaboratively and gain the trust with the care sector and engage and work closely with the care sector to understand the challenges that the care sector is experiencing. When we started our project, we understood that there was wide variation in digital literacy and infrastructure within care homes. We spent time understanding this situation to understand what support the care sector needed and to inform our project plan. This enabled us to build the foundations to embrace digital remote monitoring and other technologies. Once we built the confidence with the care sector workforce and built the relationships, we started to win the clinical hearts and minds to embrace new technologies such as digital remote monitoring. This was supported through sharing case studies and insights from the people involved and demonstrated the impact of this work. This work has now informed our future digital roadmap and has informed the development of digital leadership roles such as clinical safety officer, digital nurses, and care home facilitators.
Thank you, Gina. And we'd also like to share a little bit about the impact that this has had for our patients and our system. Building on the confidence of staff, we've managed to monitor 6,000 patients remotely. Of these, 1,000 patients have received digital remote monitoring. A very small proportion have been escalated to A&E or the emergency department, which suggests that we've prevented the deterioration of patients, but also helped them get support from hospital when needed. We're really only beginning to understand the use case of digital remote monitoring, the benefits of clinical decision-making, and the opportunities for providing more proactive care for patients. The national team believe, as do we, from the evidence we've seen so far, that this has saved lives.
Thanks very much, Jay, Mark and Georgina. Such great examples of caring for some of our most vulnerable people. And now we move our focus to COVID remote monitoring services. Firstly, we'll go to the east of England to hear from Dr. Andy Barlow from West Herts NHS Trust, the site of our first tech-enabled virtual ward, which Tara alluded to earlier. And then we'll go to the southwest to hear from Dr. Hein Leroux and Megan Isaacs, taking us through their primary care-led service in Gloucester. Some real examples of innovation and rapid changes to respond to the pandemic. We'll start with Andy.
On behalf of a large and very significant team, I'm delighted to be able to present how we went about developing a new evidence-based prognostication tool to aid decision-making into an innovative new virtual ward or platform to look after patients with acute COVID infection. The aim of this project was to deliver an evidence-based, integrated virtual hospital supported and driven by a new prognostication tool in order that we put the right patients in the right place in their care pathway with this novel disease entity, acute COVID. Secondary goal was to protect our hospital from being overwhelmed. And being as it is a very challenged estate and one of the oldest hospitals in the country with a low acute bed to population ratio. Finally, we were minded to identify likely senior skilled decision makers who would not be able to participate in standard face-to-face clinical intervention during the acute COVID crisis, but to properly utilise and recognise their skills in this new virtual hospital. The improvement principles and the goals of the project were first and foremost to drive down as far as possible mortality rates with patients with COVID. With regard to the new virtual hospital, we wanted to identify and deliver low readmission rates. We saw readmission rates as a surrogate for the quality of the decision-making at the front door. Finally, we were interested and very focused on patient satisfaction in this new process. So how did we go about this? The first step was to design a new virtual pathway. This was a 7 days a week, 14-day hospital pathway, effectively where senior clinicians delivered ward rounds in the virtual domain. Initially, this was supported by pulse oximetry, but as in later iterations of the cycle of adaptation, we folded in a new web-based monitoring program provided by Humour called Medipad. This enabled patients to interact with clinicians, provide and upload physiologic data and symptom profiling, and offline for clinicians and patients to interact together. In order to commence the pathway, we designed a first cut of what the clinical pathway should look like, and the entry criteria were designed based on data that came out of Northern Italy and China. However, we were very minded to identify a prognostication tool that was suitable for our population. And during the first wave, with a very large team of junior doctors, we organised and accrued data on all our acute COVID patients. And that led to the publication in thorax of this year of the SOARS scoring system. And this to date is still the first front door scoring system designed for decision making in the emergency department, which is not reliant on any sophisticated investigation or test result. And so we ran the pathway with this new scoring system from the end of wave 1 and through wave 2. Our key learning was that this was a safe and effective method to manage patients in the acute setting, and we're in an advanced setting to develop and deliver new COPD and heart failure virtual hospitals, which are integrated with community teams and stakeholders in our locality. Key to any new intervention is to ensure that the governance and the safety of the programme is robust. And to date, we're one of the few virtual hospitals in the UK to publish our data and subject it to the scrutiny of peer review. The first 900 patients results were published in the BMJ Open, and the reference is provided here. The table on the right-hand side actually shows the full Wave 1 and Wave 2 data set. And I'd like to draw your attention to a number of things. Firstly, the overall mortality rates were very low and actually dropped in Wave 2. And secondly, that our readmission rate from the virtual hospital again was low and fell significantly in the second data set. And in doing so, we've demonstrated that we've delivered on our initial intentions to provide a safe virtual platform, but also ensuring that the quality of the care has been very high. In relation to patient feedback, we're one of the 5 trusts to provide data for Naomi Phillips' review of acute COVID hospitals in late 2020. And we continue to upload our data to the national survey. There's a link provided here which also shows what one patient's particular views were in terms of her experience of the virtual hospital. And this was a subject of a national news article which we were delighted to collaborate with. Can you make it to the top without stopping?
If I go very, very slowly, yes.
Okay.
We know things have changed, including hospital consultations, but this one is different still. Natasha, who had coronavirus, was given a device to monitor her own oxygen levels at home.
It has been nice from the perspective of I can be in my own home comfort, with my own home comfort, and be able to monitor things and know that someone else is monitoring it. Can almost guarantee that if something's not okay, someone will ring me quite soon.
And finally, we were also delighted to be name-checked by the BMJ as one of the first virtual hospitals to open in the country. So in summary, this is an example of a new and innovative virtual platform. The key to the success of this is evidence-based decision-making, effective monitoring, clear escalation routes, and most importantly, most robust governance frameworks where departments and institutions subject their results to peer scrutiny. We believe this is a safe and effective method for managing other acute clinical pathways such as COPD and heart failure. Thank you.
We are here today to present on the quality improvement processes and outcomes seen from our digitally enabled COVID virtual ward in Gloucestershire. My name is Megan Isaac. I'm the lead programme manager on COVID and respiratory programmes for Gloucestershire, and I'm presenting today with my colleague, Dr. Heinle Root, who's one of our extremely valuable GP clinical leads.
Thanks, Megan. The overall aim of the COVID virtual ward was to monitor the at-risk patient cohort in their own homes to identify early signs of deterioration with silent hypoxia so we could escalate their care to hospital whilst also ensuring the remaining patients felt safe during their illness.
The approach to developing a COVID virtual ward was initially undertaken within a testing environment using 3 PDSA cycles, which we commenced using CCG staff and then built upon with WELL patients in collaboration with the Willing Primary Care Network. We worked with an incumbent telehealth provider called Baywater, who provided the test patients with a pulse oximeter and a digital tablet to record their readings throughout the day. We established a multidisciplinary project team who met on a daily basis to assess real-time feedback from the PDSAs and utilised this alongside emerging national guidance to construct a pathway that we could embed locally. Key themes taken from the PDSAs in regards to the clinical pathway and the technological need included the need for a 7-day service, our patient inclusion criteria, the need for engagement and education across the system as we identified the importance of all stakeholders needing to be brought into the vision for the service we were trying to deliver, a 2-way communication platform with patients, clear alert parameters that could be tailored for patients with underlying health conditions, options for patients to submit their readings via other means than a smart device as we were keen not to allow for any digital exclusion, and adaptability in line with the evolving model in response to ongoing assessment and evaluation in real time. Following a phased rollout by PCNs across the county, the team continued to meet regularly to assess the journeys of the patients referred so far. This responsive continual improvement approach allowed us to amend and improve processes as we went along. Examples of such areas are improved referral pathways and additional training for care, nursing and supported living facilities, direct referral pathways from some secondary care specialties, increased comms and engagement with primary care to increase overall referral rates, and adapted onboarding processes.
We adopted 4 main improvement principles. So first, as Megan's already set out, the cornerstone of our successful innovation was the use of model for improvement using rapid PDSA cycles. Second, we used measurement for improvement principles to help us identify and manage our patient safety risks. We had clear outcome, process, and balancing measures. Third, we used the Pareto chart principle to understand which patient cohorts were at most risk of deteriorating with silent hypoxia, and thus where we needed to target our efforts to have greatest impact. Finally, using stakeholder analysis, we identified that our 72 GP practices were very important to engage with, which resulted in such a high number of patients being referred to the ward. Our key learning has identified 4 overarching themes. So first, we defined our aim as silent hypoxia in at-risk groups, and we worked backwards to achieve this. Second, having a continuous improvement mindset and approach, we were able to rapidly adapt our model as new challenges and gaps came to light. Third, we were very responsive to feedback, which helped us get early sight of potential safety challenges. And finally, we set up a dashboard early on so we could have oversight of the processes, and this allowed everyone to focus their efforts on exceptions and also gave everyone transparency of the whole process as well as all the interdependencies.
Thanks, Ryan. So here on this slide, the main graph is showing the number of referrals to the COVID virtual ward between November and April. This metric was our main key success factor, and we've seen over 1,240 patients so far. Alongside overall referrals, we also tracked patient safety scrupulously, which we could gauge based on the proportion of patients entering their readings twice daily as instructed. If they missed a reading, they would alert on the system, which then prompted a call from Baywater to make sure that they were okay. We took many actions to reduce this number of alerts, and we found that reducing the referral to the patient entering their first reading meant that the patient was more likely to stay compliant with the process for the full 2 weeks of monitoring. We also measured the level of referrals to secondary care, which in this instance showed that the more referrals that were made meant that the ward was doing what it was designed to do, identifying those that needed escalation and doing so in time for the patient's lives to be saved. Thank you very much for your time.
Thanks so much, Andy, Hein and Megan. Again, great examples of ensuring continuity of care for people in such unprecedented times. And for the last of our presentations, but definitely not the least in terms of importance, I'm delighted to introduce Ros Davies from mHabitat to take us through their work in the North Eastern Yorkshire on inclusive digital transformation. Over to you, Ros.
I work for mHabitat, and we are a multidisciplinary team of designers and researchers and engagement specialists, and we're hosted by Leeds and York Partnership Foundation Trust. And I'm going to share with you today a brief summary of our Inclusive Digital Transformation Programme. And I have actually stuffed the slides full of more than I can talk about today, but I hope they will provide you with a useful takeaway. And please do get in touch if you want to find out more. So, as we are aware, the pandemic was a catalyst for the rapid digital transformation of health and care, but the unintended consequences were the triple whammy of pre-existing inequalities exacerbated by COVID-19 and by digital exclusion. And the people most affected by these inequalities are most likely to need health and care services. So in response to this, we embarked on a journey of discovery to understand how we might embed inclusion upfront into digital transformation. And the remote monitoring programme led by NHSX was one of the early projects that we connected with. We joined in close to home in the North East and Yorkshire, where we hooked up with the regional NHS England team and the academic health science networks. And we ran co-design sessions focused on 2 digital tools, Tyto Care and a live call. Alongside that, we delivered a regional learning programme for 30 clinicians and technicians and other people working in digital transformation. And we developed a repository to share good practice and useful tools and guides and so on. And through this, and at the end of that discovery journey, we developed a framework for what we know so far, really, about what good inclusive transformation looks like. So we learned that the risk factors, We looked at the risk factors which create barriers for people to benefiting from digitally enabled health and care are multi-layered, they're complex, and they change over time. And they include life context, for example, where you live, what's happening in your life, your income, the conditions that you live with, and so on. And they can all create quite a complex picture. But also the more well-known risk factor around digital skills, confidence and motivation, and really importantly, the system side of things, so the accessibility of tools and the skills and confidence of staff. And it's clear to overcome these barriers, we need to join forces and pool resources across sectors. So whether that be the voluntary sector, local government, academia and the private sector, they all have a part to play. So as I mentioned, we ran co-design sessions with clinicians, care workers and patients in relation to 2 digital tools to test both inclusive and non-inclusive factors. Our TytoCare is an all singing, all dancing vital signs monitoring tool, and AliveCore, a finger pad ECG monitoring tool. And I think these are 2 potential real game-changing pieces of kit. And both pieces of kit in this circumstance were being handled by health and care workers in people's homes. So they will collect monitoring information and then it could be accessed remotely by a consultant or a GP. So obviously the digital skills required in both cases were related to staff, not patients. But we discovered that life context can still be, in some cases, an excluding factor. So in TytoCare, for example, it's not always appropriate for people living with paranoia. And for AliveCore, there are physical and cultural and potential learning disabilities that can have a relation to exclusion factors. So we also learned that internet connections are not always easy to access in care homes, and it can be due to patchy broadband, and GPs don't always have the right devices to receive the information. And we also, while we were there, learned a few things about the potential issues around flow of information, which we think could be used to improve the process. So, for example, having clear policies about who interprets the data, easy read information to help prepare patients, and training care workers to build their skills and confidence before we actually get into implementation. So our overarching conclusion was that these 2 pieces of kit were pretty inclusive, and actually they could be used to reduce inequalities and increase access, and very importantly, I think, improve the experience of care for some of our most vulnerable people. So that was a whistle-stop tour, and as I mentioned, we carried out a number of different projects last year with a number of different partners and parts of the system, and we pulled together this starter for 10 on what we think so far what inclusive digital transformation looks like. And we did this because we want to help people who are interested, people, organisations and systems along their own inclusive digital transformation journey. So I hope this will be useful to some of you here today, and thank you very much for listening, and I'll hand back to Breed.
Thanks, Ros. Ever inspiring as always, and such an important subject. And we've had a specific focus on that for our regional bids this year. And for anybody who wants to know more about this subject, Ros and team facilitated a really fabulous thought leadership event recently, and the recording of that is available on the Future site. So do pop onto the site to find out more. That brings us to the end of our presentations. So thanks to all our presenters. We'll now have a quick break and come back at 11 when we'll be joined by our panel. Please do continue to pop your questions in the Q&A section of the platform, and we'll try to get through as many as possible. So see you at 11.